Medicare has sought to control costs by paying providers less than private plans.
Yes.
The president's healthcare law cut providers by $500 billion, not to advance Medicare's solvency, but to fund another open-ended entitlement program. On top of that, physicians are set to be cut by an additional 29.4% this January. I believe it's 29.4.
Yes.
Do your projections assume providers will continue to accept Medicare patients at the same rate that they do now under the traditional program? Because let's remember, Medicare already pays providers 80% of what they will receive in the private market. By 2030, this will fall to about 40%. So do your projections assume providers will continue to accept Medicare patients at the same rate they do now under the traditional program? And does your analysis assume, despite the additional provider cuts coming in current law, that this will have no effect on the quality or access of care?
The way I would put it, Mr. Chairman, is that we don't model the behavior of physicians. We don't model the access to care or quality of care.
So you assume it stays on as is?
And that is the point that we noted in the letter analyzing your proposal. That is a gap in our toolkit and a gap that we are trying to fill. But under the current circumstances, we don't model, either in the regular baseline projections or in our analysis of last year's health legislation or your proposal, the effects that might happen under current law or alternatives.
Yeah, so therein lies the issue here. Your analysis effectively assumes that no matter how much the government pays providers for healthcare services, providers will continue to deliver the same quality care and access. That's the gap you talk about. While you accept the premise that the imposition of price controls actually reduce costs, it strikes me that your analysis does not appear to take into account that choice in competition, despite working nearly everywhere else in our economy, and even within Medicare where applied, will put downward pressure on health inflation. So is the takeaway here that the only way to get a grip on skyrocketing healthcare costs is through strict price controls and heavy government rationing? Is that what we are to conclude from all this?
No, I don't think that's a fair interpretation of our analysis, Mr. Chairman. As you pointed out yourself, Medicare pays less to providers today than private insurers pay. So it is, I think, an open question as to how much lower payments can go in Medicare relative to private insurers without hindering the access to care or quality of care of Medicare beneficiaries in an important way.
But in your analysis, you just don't feel like you had the toolkit to model that. Is that what you're saying?
To model that. We also noted in our letter that we do include the effects of competition in the current private insurance market in assessing the gap today between the cost in Medicare and the cost of treating a similar patient we estimate outside of Medicare. But we do not, in the analysis, incorporate any effects of competition that might arise over time from the additional price pressures and that are built into your proposal, and from the additional flexibility that the insurers have relative to traditional Medicare to adjust